A gift is a thing given willingly to someone without payment, a present. When one person agrees to be a donor, it begins the process of the greatest present. Organ donation, the gift of life, tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Being an organ donor is being willing to give one of the greatest gifts possible. If you donate a kidney or part of your liver to someone, it's being willing to take a risk, albeit a small risk, to help someone who desperately needs the functioning organ. If you donate your body for donation after death, it's a gift to potentially dozens of people of the gift of improved conditions of life or even life itself. First, let's take a look at this week's Prairie Doc quiz question. While one person's death can be tragic, that one deceased donor can save up to how many lives through organ donation and can save and enhance more than how many lives through the life-saving and healing gift of tissue donation? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in on that quiz question. We answer your questions about organ donation as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Join us tonight are Doctors John Berdahl, ophthalmologist with Vance Thompson Vision in Sioux Falls, and Dr. Robert Santella with Avera Medical Group Nephrology, Sioux Falls. Thank you, gentlemen, for joining us.
Glad to be here.
So I did allude to the issue of organ donation versus tissue donation. Bob, can you start with that? What's the difference?
Well, organ donation is solid organs, heart, liver, kidney. Tissue donation, John can speak to.
What is a tissue donation?
Well, we're not quite as sophisticated as the organ donor surgeons, but the eye is comprised of very important but very small layers that don't constitute an organ, and when we replace one of those layers, that's a tissue donation. And there's other types of tissue donations, skin grafting or patellar tendons and things
heart valves.
Heart valves that aren't actual organs in and of themselves.
People who have a bone replacement surgery need bone parts. I mean,
exactly.
That's tissue.
Mm-hmm. Exactly.
Sure.
So that's a very important, and the quiz question turns around those two issues: tissue, cornea, organ, kidney, and there's all sorts of others. So what are the numbers? I mean, we know that there's also a difference between a live organ donor and a deceased organ donor. Touch base on that, Bob.
Well, for some organs, like kidney especially, there can be a live donor. You can live with one kidney. If you're very healthy to begin with, you can give up a kidney and donate to someone. That's about 1/3 of all the kidney transplants in the U.S., and then about 2/3 are from deceased donors.
People were in a motorcycle accident, and their brain is dead, but their body's still working, and they have it working when they take the donation.
Exactly.
And that's interesting. There's more deceased donors than there are live organ donors.
Yeah, that's one big push, is to try to get people on their driver's license to become organ donors. But there is still a limit, and really the potential there to solve the problem is with living donors. So there's 100,000 people waiting for kidneys. We only do 20,000 a year. Do the math, the list grows every day. And so the answer will be eventually in living donors, more living donors.
I've heard that like 0.5% of the population that were able to donated, there would be no need for...
Sure, there's only 100,000 on the list.
Yeah, so I mean, it's just a wonderful gift. I think about Jim Abbott, who was the president of USD, what a gift he gave to one of his college professors. It makes me cry to think about what a loving, caring gift that is.
We're actually seeing more and more. We're now seeing Good Samaritan anonymous donors who don't have an individual in mind. And in fact, we did one at a very yesterday.
Why do you think that is?
I don't know. I think we're in a really giving area of the country. I think there's awareness, but it does amaze me. I mean, it's very impressive.
So Jim Abbott gave a kidney to his college professor, and they're doing that as a gift I'm always amazed at the beauty of that. I mean, talk about having meaning in your life. At the end of your life and you're on your deathbed and you're thinking about, what did I do with my life? There is something that you can hold on to and say, wow, I saved a life, for sure, in that case.
And people have a very, very positive outlook on life afterwards. I mean, most people tell you it's the best thing they did in their life.
But there's a little risk.
Small risk. If you pass all the evaluation, if you have normal kidney function, you're healthy, we won't take anybody that has more than a 1% risk of kidney failure later in their life. And most of the people we see, we estimate their risk is well under 1%. And we have a risk, of course. We have about a 4 out of 1,000 risk of getting kidney disease. And that might go up to 6 out of 1,000 if you donate. So the relative risk is high, the absolute risk is small.
Really small. You only need 2/3 of one kidney to do well in your life. Any comments about?
Yeah, so on the eye side of things, almost all of it is deceased donors, but not all of it. We actually do limbal stem cell transplants.
Say that again?
Limbal stem cell transplants. Limbal stem cell transplants. Limbal stem cell transplants. I got it right the last 3, but not the first one.
So now you got to tell us what that is.
Yeah, right. So the limbus is where the colored part of your eye meets the white part of your eye. And there's stem cells there.
On the edge of the eye.
On the edge of the eye, where the colored part meets the white part. There's these precious cells that live there. And what their job to do is to replenish the surface of the cornea. So like if you scratch your skin, that scratch goes away and those cells are always sloughing. Same on your cornea. If you've ever scratched your eye, it hurts a bunch.
And then it fixes
itself. But if you don't have those limbal stem cells, you can't fix it. And so it's a really difficult problem. It's uncommon, but we'll use living donors for that. We'll have deceased donors for cornea transplants, and then we actually even use amniotic membrane tissues that we put on eyes. So the lining of the placenta, because of all of the good growth factors and healing factors, they make almost little contact lenses that you put on the eye to heal some diseases.
Well, and also those are plural potential, aren't they? I mean, they're stem cell. I mean, they can do anything.
Yeah, they can. We want them to just fix the eye when we put it on there.
We don't want an ear there
That's
or
right.
a nose.
That's right.
Just an eye.
That's right.
But the cornea, it's interesting. I've said often in many essays, every single cell of the body gets a blood supply, and the blood comes out with oxygen, takes out the carbon dioxide, and gives nutrition to that cell. Those tiny little muscles out in the periphery and everything, but it's not true about the cornea.
Yeah, you've been lying to people for a long time. The truth is, in the eye, there are a couple of tissues that don't have a blood supply. The cornea is one of them, and the lens is one of them.
So those are non-blood supply, because they're transparent. They need to be
clear.
They don't need to have
their
blood
job
vessels.
is to let light through, so they can't have blood vessels.
So where does the lens get its nutrition, and where does the cornea get its nutrition?
Yeah, great. So it's bathed in aqueous humor.
That you can say that, and it's not funny, right?
That's right. And an aqueous humor is like plasma minus the red blood cells. Plasma doesn't have red blood cells, but
the red cells have been spun off.
That's right, and minus
plasma.
the protein, but it has a high oxygen concentration, and so it works by diffusion.
But it's good that the cornea doesn't have a good blood supply, or any blood supply, because it can't reject.
That's exactly right. So
it doesn't reject.
That's exactly right.
You don't need,
as opposed to limbal stem cells, you need to be on anti-rejection medication because it's vascularized tissue, so it has blood cells. So the cornea can reject, but it's uncommon. We don't have to match blood type. We don't have to match tissue type. All we have to do is have people be on a steroid eye drop for about a year.
Right. Now, and I've read that the nutrients and all of that really is in the tears for the cornea.
Yeah, so the outside of the cornea breathes the air from the outside, and the nutrients comes from the tear film, and some comes from the aqueous humor that's inside the eye.
Wow.
And there's about 80,000 cornea transplants a year.
80,000 corneal transplants a year. Now, there's a
but there's no shortage. That we were just talking about that.
Yeah, that's right. That's right. So we are, the United States is net exporters of corneas. What that means is that we have more corneas donated than are used in the United States.
But they're all deceased donors.
But they're all deceased donors. And so the way, if you had Fuchs dystrophy, the most common reason for a cornea transplant, the inside layer of your cornea isn't functioning well.
So, I mean, here is your cornea, the outside.
Here's your cornea.
Is okay. It's the inside.
Inside layer, these little cells, their job is to pump fluid out of your cornea into the eye so your cornea doesn't swell, it stays nice and clear, and you can see well. That's their job. And if they start to kind of poop out as you get older because of Fuchs dystrophy, which is a genetic disease, but it doesn't show up usually until until your 50s. If those cells stop doing their job, the cornea will swell, and then it's kind of like looking through ground glass, and glare bothers you when you're driving at night. And if you came in and saw me and you had that condition, I'd say we can fix you. And it'll a surgery that takes 15, 20 minutes or so. We'll remove the diseased tissue, put new tissue in. I say, when would you like to come in for surgery? And you say, well, I'd like to come in 13 days at 10:30. I'll have a cornea for you there in 13 days.
Because you buy it off the shelf.
Because we get it from our local eye bank, and we order it, and it's there. And it's just amazing how this came about. The first cornea transplant was in 1905.
Because rejection wasn't a problem.
Well, it didn't work.
Oh, it didn't work.
But it was the first one, and they tried it. And it used to be that a real issue with corneas was you had to get them right after somebody deceased, because they couldn't preserve them. And so the state patrol would be driving, corneas to somebody in the middle of the night, and the surgeon would take it. And now what happens is somebody passes away in the hospital. An organ donation team talks with them.
With their family.
With their family. And they, they confirm that they wanted to be an organ donor, and they recover those tissues, and they preserve them in a solution called Optisol that has a very high oxygen tension and some antibiotics and things to preserve it. It was actually invented by my mentor, used across the world, his biggest contribution. And it allows us to preserve that tissue in the United States for 14 days, and if it isn't used in the United States over 14 days, then it's shipped overseas, because it's still probably good for about up to a month.
Wow. Why don't we have enough kidneys to transplant? I mean,
kidneys are a little more complicated than a piece of lens. A non-vascular tissue.
I'll second that. Okay. It is true.
So, organs like a liver, you've got 6 hours. A kidney, we can go 24 plus, but you have, it's shipping across the country, it's matching, it's a big
it's got to be just the right
undertaking. Yeah.
But
and then there's not enough organs. So there's a big long list, and matching and priorities, and it's difficult.
How likely is someone a match? So how likely is it that you're a match, or
so we have to have blood type compatibility, what we all learned in medical school, ABO, blood type, right? Blood type compatibility. And then the recipient, and then separate from your blood type is your tissue type. That tells me from you. It's our immune system.
Is that HLA?
Yeah.
Okay.
And so when a virus or a bacteria or a cancer cell is formed in your body, then your immune system says, hey, that's not me, and attacks it, okay? Right. So we normally don't have antibodies to each other's tissue type. And we may match tissue type, we may not. There's a number of tissue markers out there. But we generally will maybe match a tiny bit, but usually not. But the recipient can't have antibodies to the donor. People develop antibodies by pregnancy, blood transfusions, previous transplants. So a bunch of people can be incompatible for various reasons, and that becomes a problem between tissue type and blood type compatibility. But now we have what's called, for living donors, paired donor exchange.
And you know what, I want to get into that paired donor exchange, but I want to take this first roll in. I would say this, that it's just fascinating how we started realizing with blood transfusions all of this stuff in World War I, really, and it just exploded into where we now have immunological drugs for cancer, and so on. Well, we can talk more about that. I want to hear about this paired donor exchange thing. But remember, we depend on your calls. Please give us your calls. Many situations can bring someone to the need for transplant. How one gets there, the timeline, and the people who step up to help can be quite a story.
Being a doctor and therefore a lousy patient, I randomly took a chemistry on myself one day and found my lab work that was consistent with decreased kidney function was elevated. I went to see my colleagues and we started treating, and 6 months later it was even worse. Given that my findings were consistent with some kind of cystic disease, but not polycystic kidney disease, we found the specialist in the Mayo Clinic in Minnesota. I called them, made an appointment, saw them, and was diagnosed with tuberous sclerosis complex, which very rarely affects the kidneys in middle-aged. Usually it presents in the very young patient with severe cognitive impairment, among other things. My kidneys failed to the degree that I needed dialysis in April of 2015. I was on something called peritoneal dialysis that you do with a catheter in your belly nightly at home when you're sleeping. My kidneys progressed to a degree that wasn't good enough. And in February of 2018, I began hemodialysis 3 times a week at the center. With dialysis, you run the risk of increasing progressive medical problems, cardiovascular, among other things. Also, you have a decreased function because during dialysis with kidney failure, you just don't simply have the energy to go about. So having that kidney transplant brings you back to an energy level, and you can continue being a more meaningful contributor to society. But I can only say that the cost of keeping someone on dialysis per year is exorbitant compared to what the cost of anti-rejection medicines post-transplant would cost the system. There is data that shows live kidney donation has better post-transplant organ survival than a deceased donor one. But in the modern age of increasing quality, some of those numbers may ultimately come within, less than significant figures. I've come up close to getting a kidney a number of times. There has been a few live donors that were on the verge of coming and getting worked up, and for personal reasons, they had to step back, understandable personal reasons, about 3 of them. I've gotten up to the deadline, even with deceased donor kidneys, up to the night before, when it was determined that kidney was not quality, so they canceled the transplant. And probably all in all, about 12 near misses, so to speak. So even though something is on the verge of happening and my friends and colleagues say, "Are you excited? Are you excited?" I always respond by saying, the opera ain't over till the fat lady sings. An otherwise healthy person uses approximately 2/3 of one kidney function. Therefore, they could, to use a quaint expression, share their spare.
That was a dear friend of mine, Stu, and we just are praying for you, Stu, and hope that one of these times, these many times of waiting that one of them will slip through and you'll go, oop, new kidney. But tell us about the experience that you've had. I mean, how does that go usually?
Kidney transplants, it usually goes pretty well. Because of the shortage, we're expanding and using older donors. And so if you have a young, healthy donor, it goes very well.
So, I read in the Journal of the American Medical Association this week that that we are too stringent in the U.S., and that people are doing very well in Europe and other places with taking older donors and less perfect kidneys. Why is it that we're so stringent?
A few reasons. We do have a high discard rate. One reason is there's a lot of government regulations, and we're held to very, very strict outcomes. And so most programs will tell you that we turn down marginal donors that we think may or may not work well for fear of
getting rejected from the government and not being able to do kidney transplants.
Right. And then I think there's an expectation from the public that you can fix everything perfectly. So when you say, people really don't understand when you say this is your outcome on dialysis, and would you accept an older donor as well as a younger donor? And you discuss the pros and cons. I don't want an older donor, it won't last as long. Although they'll do much, much better with any transplant compared to dialysis, and that's a difficult sell sometimes.
Do patients get input on whether or not the parameters of the donor that they get?
To a certain extent, for older donors with an infection risk, things like that, we tell them up front, we get their consent. For a donor that has no issues whatsoever, it's a slam dunk, and we don't really discuss it. And there's privacy issues, and this is a small world, so that you have a deceased donor, and a child dies in an accident, and you don't want to reveal that. So, but we do tell them if there's any risk involved, and they can make an informed choice. And we'll never put in a kidney or a liver where we don't think the benefit far exceeds the opposite.
I think about the cost. Surgery and transplant and immune drugs and all those things. The cost of that surgery is quite high. But what about the cost of dialysis?
Dialysis is expensive. If you include dialysis access, the method to get to the blood to the machine, it's $80,000 or $100,000 a year. So a kidney transplant's probably $80,000 or $100,000, and then you've got the medications, which are $10,000 to $20,000 a year. So by the second year, you're already saving money.
So the government would be smart by encouraging more dialysis. Well, what about the advantages?
The government shuts off payment for medicines after 3 years.
Shuts off payment for anti-rejection medicines?
Yep.
Why?
Does the rejection rate go that low?
No, they need them for life. Yeah, go figure.
Why is
We've had a bill before Congress for the last 15 years. Yeah, it's politics.
But the dialysis is way more expensive. They don't cut that off.
No.
Well, they're shooting themselves in the foot.
Absolutely. Yeah.
We
Welcome
need to talk
to our world.
We need to talk to the government. And this has been going on for a long time.
Yeah.
Well, I just think about the fact that if you're on dialysis, your longevity is this much. It's way better.
Oh, double to triple with transplant. Yeah.
So you're doing real organ transplant. So I just want to make sure that I heard everything right. It's cheaper to have a kidney transplant.
Correct.
It's better to have a kidney transplant, but we won't spend the money to do something that's both cheaper and better.
Right. In terms of the medicines. I mean, we get by and there's support and people have private insurance, but there are people who lose their kidneys because they can't afford the medicine. Yeah.
We have some questions. What is the process of harvesting a cornea? Harvesting.
Yeah.
That's a kind of a
procuring.
Yeah.
That's a South Dakota word. Right?
Yeah, right. We typically say recover tissue.
There you go. That's better.
And the process goes like this. Someone passes away that's an organ donor. whether it's in a hospital or at home or wherever. And either the recovery technician goes to the funeral home, goes to the site, goes to the hospital and recovers the tissue there, or more frequently they're brought to the Dakota Lions Eye Bank in Sioux Falls, and the tissue's recovered there. And then it goes through a real stringent process. They have to look through reams of paper with bad doctor handwriting, although EHRs help with that a little bit, but reams of paperwork to ensure that there aren't some communicable diseases that patient would have had. Right. And then we test to see the number of those precious cells that I talked about on the cornea to make sure that those are okay. And if it meets all the criteria, then we can transplant them. And you mentioned something that was interesting about having input, because cornea recipients really don't have input on their individual cornea.
But are they all of equal quality?
Yeah.
The outcomes are good.
They're all, there's nothing that's
good.
given, there's no criteria where a tissue has a higher likelihood of failure when it's transplanted in the United States.
And an old 85-year-old person's cornea can be transplanted and it will last just as long.
Yeah, in general. In fact, for some types of cornea transplants, we don't like younger donors. Because their tissue's too flexible that surgically we can't get it to unscroll the way we want to in the eye.
One of the things you said earlier that surprised me was that there's more Fuchs dystrophy cornea transplants on the inside of the cornea than it is
full thickness cornea. Yeah, that's right. So full thickness cornea transplants used to be how we would do all cornea transplants. What you do there is you would take a tree fine, which is essentially a blade that's 8 millimeters round, and you'd create a manhole cover in the cornea, and you'd cut that out, and you'd take and punch another cornea that fits that, and you'd sew it together with 16 little stitches, and it would give people their vision back. Tiny itty bitty stitches.
By hand? By
hand. And we still do those cornea transplants for corneal scarring or for a disease called keratoconus, although it's much less frequent that we do that now because we've got other treatment alternatives like cornea cross-linking. But we still do that. But about 10 years ago, some pioneering eye surgeons said, I don't think we have to do that. We can just replace the diseased layer. And like any pioneering surgeons, they were lambasted for a while until they were heralded as geniuses. And and so we replaced just the inside layer now. And Fuchs dystrophy is the most common reason for it.
Okay. And you don't need anti-rejection drugs?
Well, not really.
Except for that
not oral. You take a steroid eye drop, and that decreases the inflammation and the likelihood of rejection.
Okay. What's your reaction to what he just said? I wish it was simpler and
yeah. Do you still have to sew then on the inside?
One stitch to where I put the incision at.
Okay, sure.
And it's a tenovicryl, which is a tiny thin little suture, and it dissolves in about a month. And so it's really slick. And one thing that just a quick funny story. I did have one patient that requested, something special about his tissue, and he was a liberal, and he really wanted to have a cornea from somebody who was also liberal because he didn't want a conservative bone in his body. And I said, well, it's not a bone.
So I'm thinking about kidneys. Do they always remove the old kidney?
No, almost never. Only if it's a problem. Polycystic kidneys, infection or polycystic kidneys can be so big into the pelvis you don't have room, or if the polycystic kidneys are causing severe pain. But otherwise, the new kidney goes down in the pelvis in the front, and the old kidneys are in your back, up high towards the back in the
behind the peritoneum.
Right.
Now, is the peritoneum is the sac of the abdomen that holds the guts.
And so the kidneys are in the back.
Behind the peritoneum.
Yeah, much closer to your back than your front. And the new kidney goes down into the pelvis.
Outside the peritoneum still.
Correct, right.
Okay.
For a few reasons. The length of the ureter, blood supply comes from
top and bottom, and you have to cut the ureters. So if you make a really long, the tube that goes from the kidney to the bladder, if you make that too long and you cut off the blood supply, that part will die. So you need a shorter ureter, and you're limited vessels, and it fits right into the iliac artery. The artery goes from your abdomen down to your leg.
So you get a good blood supply, you're short enough to put it right into the bladder. And
But I am jealous about the rejection issue.
Yeah.
Because that's the downfall of solid organ transplant. We have to use powerful immune suppressing medicines.
But we're so much better at it. I mean, you're using 22 single shot rather than
We're a little better
shotgun
at it,
12
but
gauge.
it's still not precise enough. So that your immune system, after you get an organ, your immune system is suppressed, and you have an increased risk of infections and some cancers.
The most common infections?
A variety of infections. Most common, go ahead.
Yep,
Most common cancers would be skin cancers, which usually don't think much of, but they can be invasive and lethal sometimes in transplant patients. Urogenital cancers like cervical cancer, viral-induced cancers. Some cancers are from viruses, like cervical cancer,
for example.
And so that's increased quite a bit.
So
Lymphomas.
Yeah. So I've had pancreatic cancer. I'm not a candidate to donate at all in any way, what shape or form, am I?
No, well, I don't know about corneas.
We'd take your corneas.
Oh, you would?
Yep.
Good. That's an interesting thing. Now let's talk about, I appreciate that. Thank you. You can have
Thank
them.
you. I hope we don't get them for a long
Let it
time.
be a long time. Let's talk about different kinds of dialysis. Is
Okay.
one, I know hemodialysis is, you take the blood, you filter it, give it back. And peritoneal dialysis, you put in the fluid, it kind of takes out the poisons, then it dumps out, and then you just repeat that fluid in the peritoneal cavity.
Right.
One better than the others?
No. It's all about convenience. One's a little cheaper than the other.
The peritoneal dialysis is a
Yeah,
little
that's
cheaper.
the president's push. I mean, but it doesn't save lives. I mean, it's the same.
It's the same risk and about the same cost.
It's a little cheaper because when you come to a center, you have individual nurses hooking up to a machine, whereas you're doing your own dialysis when you do the peritoneal dialysis at home. So peritoneal is a little bit cheaper.
Okay, and is it easier? You can just do it when you're sleeping, and then you don't have.
Yeah, it's easier, but then the patient has to
Know what they're
take the
doing.
responsibility. It's pretty easy to teach, but someone's got to want to do it every night at home, rather than some people just say, "I want to just drive to the center. You hook me up. I don't want to deal with it."
Yeah.
What's the split?
80-20. 83-17 hemodialysis in center.
So even though maybe it's less expensive and perhaps more convenient, people are more comfortable with a professional taking care of it.
That's true. And then some people just really aren't capable. Or if you've had a lot of abdominal surgery, you can't have peritoneal dialysis. But we should do more. Europe does more peritoneal dialysis. That was the president's executive push, was more peritoneal dialysis.
President
Trump had a big executive order about kidney disease, which was so-so in terms of its,
I didn't realize he had made a comment.
Yeah, him and Alex Azar, head of HHS, had some ideas on expanding home dialysis and expanding transplant. But I think you have to, to expand home dialysis, I think you have to provide a financial incentive for dialysis companies, hospitals, docs, to really push it.
Because it's only 20% of the cases
It's
right
maybe less, 17, I think it is, something like that. Higher around here, because we're more rural, and people
Like to
have
be at home?
they have to travel to a dialysis unit, and that's a burden.
now. Yeah.
So
What size of town would have a dialysis unit?
it depends on the town fathers and how pushy they've gotten, but you need, it's not cost effective unless you have 20 patients, but there's a dialysis unit in Brookings, Mitchell, Aberdeen, Sioux Falls, Watertown.
And a couple in Sioux Falls. Mm-hmm. So what changes when you only get one kidney, you have a transplant? Is there less ability to do anything, or what happens?
No, you got to remember the dialysis provides about 10 to 20% of the filtration of our kidneys. And then it doesn't do things like, the dialysis can't make vitamin D or fix
hormones.
anemia or hormones. And so all that's fixed by one kidney. And your filtration rate is lower with one kidney than two, but you can get by just fine. It will not last the duration that your kidney would last in you or me, though. And that's, you know, it's been in an ice box for 20 hours, and it's already been used a little bit. And there's definitely subclinical rejection that we have trouble monitoring and treating, and high blood pressure, and et cetera.
There's all sorts of...
And, you know, half the patients are diabetes, they still have diabetes. If they're diabetics, they still have diabetes.
You mentioned earlier to me, I think before we were on the show, about transplanting more organs than one. Tell me about that.
It's common for liver failure patients to have kidney failure as well.
Right. Do we know why that is?
There's...
when your liver fails?
Everything fails, yeah. I mean, these people are very, very sick, often in the ICU, days to live sometimes.
So you sometimes transplant a kidney and a liver at the same time?
Mm-hmm. We did one last week at Avera. Yeah.
You were going to tell us about paired donor exchange?
That's very exciting. Back
to this.
That's
Sorry.
really exciting. So let's say you need a kidney and your wife is incompatible. Okay. And I need a kidney and I'm incompatible with my wife. My wife gives to you, your wife gives to me. So that's a simple two-way swap. We have everybody that's incompatible is in a computerized database, and the computer matches them up. But when it's really good is when we have one of those anonymous Good Samaritan donors. So they start a chain. So the Good Samaritan gives to you, then your wife's ready to give to me, and then my wife's ready to give to the next one, and the next one, and the next one.
That's
and
incredible.
Yeah.
It's like a kidney conga line.
That's right.
Kidney
exactly.
conga. Say that 3 times really fast. Sorry. So I think that's really hot right now. I mean, I heard that from Stu.
It's really working. It's increasing living donation, and we're part of a 30 swap chain next week. Yeah.
A what? A 30 swap?
30 swaps.
How big have the swaps gotten?
I don't know how big it's gotten.
Well, Stu was talking 50.
Yeah.
It's amazing.
Yeah. That's amazing.
Really
and so one benevolent donor kicks off this chain, and the chain is all in place, ready to go.
Right.
And then you get that one donor at the beginning
Because the computer's always looking. Like we'll have a new pair. You know, I saw patients today. We might have a pair to enter into the system, and the computer's always constantly matching.
It's amazing.
Yeah. Huh. Wow.
You know how it started? It'll take a little bit of time. So this Wall Street guy had a big company. He was he did the all the stock market before the internet, all the paper, you know, confirmations had to go out within 24 hours or something. He had this big giant company, his daughter needed a kidney, and no one in the family could give a kidney.
Match.
Right. So he goes, well, let's do a swap. He's a smart guy. And we don't do swaps. He goes, well, yeah, you got to do swaps. And so he sold his company, started this company. I think they only have like 8 employees because it's all computer-based. They're going to reach 4,000 kidneys this year that they've done with these swaps. And he believes in it so much that he and one of the other 8 founders became Good Samaritan donors and started chains.
Wow.
And this thing runs like clockwork. I mean, they are precise. And then and we get fined. I mean, if we don't have our data in there ready to go, you pay to join this system, and you've got to be right on your game. But because they make everybody be on their game, it's fantastic. It's really amazing.
Wow.
They will do 1/6 of all, if they continue to do what like they're doing, they'll do 1/6 of all the living, they'll be responsible for 1/6 of all the living donors, kidneys in this country next year.
Wow.
Yeah, it's really
neat.
Smart Wall Street people.
A loss of a child is devastating to parents. A small measure of comfort can come from the knowledge that your child is living on in the lives of the people who receive the gifts.
I'm an organ donor on my card. Are you an organ donor?
Yes.
So we've just always thought that that was the right thing to do. And turns out our daughter had marked organ donor on her card too.
She gave the gift. She was a loving child. She was happy. And in doing that, she gave a gift that you would say is a common gift that was not many people are willing to sacrifice. And so she had done this already in advance.
And then we needed to make some choices about if her body would be viewed at the funeral, then that would impact what they would choose to do. And that took us a while, and I think it was
Saturday morning.
Yeah, or maybe Friday night
Right.
when we finally said, we already had said we would have a cremation, so that impacted how they were able to do things. And then Friday night, finally, we said there would be no viewing of the remains, they say, which meant that she could be an organ donor.
And a body donor.
And they call it tissue donor.
Tissue.
Organ and eye and tissue is, I think, how they say it.
What is the body after you're passed on? It's a physical, biological material. And so if you can give life to someone else and they can extend it and help other people, I think that's very appropriate. I don't see any problem in doing that.
And like Brian said, our son had hip surgery, and in the surgery they had to replace some tissue, and it was donor tissue, and that was awesome. And then Deidre passed, and then August had another surgery this spring on his other hip, same thing. And it turned out he needed donor tissue for that too. But that was a whole different realization for us about how somebody went through this and donated that, which was really awesome.
Yeah.
We don't know what the future holds. You don't know what might be possible. And if you have a chance to make a difference after you're gone, being an organ donor is the best chance really to do that.
It's the final gift. If you were to consider the last gift that you could give somebody is the gift of life. And having seen now and experienced it, it gives you a crying, joyous celebration, because knowing that at least 7 people had their lives extended and you don't know who they are, for all we know they're making big changes in life. If she has any influence on them, they're definitely fired up. So she was energetic. She loved to debate her dad.
Well, I thought that story, you can see it was a very heartfelt, difficult time for a family to lose your child, but to give the opportunity of life with that. I just thought I'd ask each of you to make a comment about it. John?
When I think about, I think that they said it so beautifully, and you could see their emotion. And I think about it as it's our best way to achieve at least a measure of immortality, because we actually do live on in someone else. And that kind of legacy is just incredible. And at the eye bank, there's a lot of letters that go back and forth, and they're just the most heartwarming letters on both sides of the equation that you would see.
Yeah. Bob?
It's so powerful, so moving, so sad, but so hopeful. It is a beautiful story.
That was a beautiful story. Well, I mean, we've got a little bit more time. I thought we might talk about what isn't working right now and what's in the works to try to fix that. I'd throw it at you.
Well, I think in iBanking it works pretty good. I think that there's some regulatory concerns that you brought up that maybe sometimes, although maybe well-meaning, aren't allowing people to get the help that they need. But I've got some example stories of how it's worked well. And one is that my dad had Fuchs dystrophy.
Yeah, let's hear you did a TED Talk.
Yeah.
I need to hear that TED Talk story, John.
So I got to give a TED Talk with my dad. We did it together, and you can YouTube it or whatever.
Where you go to TEDx?
You can go to TEDx, you can go to TED, or you can go to YouTube and just type in, John Berdahl, and it'll pop up somewhere.
Right.
Type in Alan Berdahl. My dad will be happy.
Okay. How much time do we have? I'm not getting an answer, but so let's roll.
Got it. So my dad had Fuchs dystrophy, and I diagnosed it when I was a first-year resident. It was the first time I'd ever diagnosed Fuchs dystrophy, and I said, Dad, you're going to need a cornea transplant someday. And then, about 10 years later, I've got my hands in his eyes, and removed the cells and did his surgery. And it's just one of those moments that you can that's a real hang your hat on moment to be able to do that for your loved one. Now, maybe the most powerful story that I've ever had happen to me in medicine. Yeah, so this is my dad's surgery right there. That's his eye. He had a cataract. You know, that's me doing the surgery. And we're removing the cataract. And that's the lens going inside the eye for the cataract surgery piece of it.
Unfolded into this nice
unfolded. And now we're removing that diseased layer of cells that's on the inside layer of the cornea. And now that's the new cornea transplant going in. That's stained blue so we can see it. We put that little tiny 10-ovicral stitch, you know, in the eye. You can see how much smaller it is than an eyelash. And then it's kind of like unfolding a ship in a bottle, because you can't touch those cells, because if you touch them, you'll kill them. And so you get this graft to unfold by kind of doing this tap dance on the outside of the eye. And then you go inside the eye and you put an air bubble in. And that air bubble holds the new cornea transplant in place, kind of like a window cling on a car. And then those cells start to pump and they create a vacuum. And it sticks to the back and it clears out all that extra fluid, and then you can see. And you know, he ended up 20/20 and doesn't have to wear glasses for distance vision and can drive safely, and just really is a joy.
And so take the next step. What happened about your father-in-law?
Yeah. So this is the most powerful thing that ever happened to me in medicine. This is about, 5 or 6 years ago now. My father-in-law passed away. You know, and I think that it's so important for us doctors to recognize the human side. It's too easy to get robotic. And this just reminds me of that every time. My father-in-law died and we were sad, and my wife gave the eulogy and she nailed it. And I went outside afterwards, and he was a simple guy, you know. Him dressed up was wearing overalls with a shirt underneath it.
Yeah.
And so I saw his friend, and I said, hey Steve, how you doing? He says, I'm doing terrible. I miss Tom so much. And he said, I've been sitting here all day long listening to the song Spirit in the Sky because it was Tom's favorite song. And so I gave him a hug, and I kind of went back to my life. And a week later, I'm in the operating room. And I'm getting ready to do a cornea transplant, and we always check the tissue to make sure it's satisfactory. And I look at the date of death, and it's my father-in-law's date of death. And I look at the time of death, and it's his time of death. And I look at the cause of death, and it's his cause of death, and it's his cornea. And I'm like, this is cool, and I'm okay. I get locked in, because that's what we're trained to do. I don't tell any of my nurses. I sit down at the microscope, and I make the first incision. And 2 seconds later, the song Spirit in the Sky came on the radio. And it makes you realize that there's a lot more than just the science to what we do.
There's a lot that's beyond science. What, 10-second comment, bottom line?
Sign up to be an organ donor on your driver's license.
Agreed.
Thank you both so much for doing this. And now for the answer to tonight's Prairie Doc quiz question. While one person's death can be tragic, that one deceased donor can save up to how many lives through organ donation? And can save and enhance more than how many lives through the life-saving and healing gift of tissue donation? And the answers are 8 lives can be saved, and over 100 lives can be enhanced with one donor's gifts. We'll be right back after this.
Extra, extra, read the Prairie Doc Perspectives weekly column in your local newspaper. More than 100 newspapers in the region print the newspaper column written by Dr. Rick Holm, covering a variety of medical and health-related topics. Ask your local paper if they carry the Prairie Doc Perspectives.
Here's a story and a formula to save a life. A dear physician friend of mine who practices in Florida developed renal or kidney failure a few years ago at the age of 60. He was initially treated with peritoneal dialysis, which involves automatically, with machine, 3 to 4 or 5 times per night, flushing special fluid into the abdominal cavity, letting it sit for a bit to remove poisons, and then draining out the contaminated fluid. This happened 3 times a week. Later, he moved to hemodialysis, where blood is drained from his arm into a filtering machine where the blood is cleared of the same poisons and then pumped back into his bloodstream. This is also done 3 times a week, taking 4 hours at a sitting. It must be a burden to be required to do dialysis 3 days a week or more for something that most of us take for granted. Since a transplanted kidney is much cheaper than dialysis and is easier on the body, it would be preferable for most people to get a transplant. However, finding a transplant organ can be difficult. In the last year, my friend has had at least 4 scheduled transplant dates, only to be turned down at the last minute. How frustrating that must be. The National Kidney Foundation notes that more than 120,000 people in the U.S. are currently on the waiting list for an organ, and 100,000 of these are for kidneys. 6,000 living and 12,000 cadaver kidneys are transplanted each year in this country, while 20 people die every day waiting for an available organ. Organs that are commonly transplanted from living or cadaver donors include kidney, liver, heart, lung, pancreas, even small intestine. Transplanted tissues include cornea, skin, heart valve, vein, tendon, ligament, and bone. A healthy living donor may be related or not to the recipient. It is a courageous and altruistic act of loving kindness to donate an organ so another person might live. To explore becoming a living donor, go to organdonor.gov. This gift of life has remarkably minimal risk to the donor and, depending on the organ donated, usually means just a few days in the hospital. While you're thinking about it, talk to your family about your intentions and mark yes as a potential donor on your driver's license. Please consider organ donation a most precious gift to someone in need, like my friend in Florida. It takes courage, but you will save a life. My buddy in Florida says organdonor.gov is another site to look into. A big thank you to our guests Robert and John for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University. Their experience brought an important subject into a bright light. Remember, we're getting into the annual flu season. It really isn't too early to get your flu shot. It's important not just for you, but to help protect those around us. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
A diagnosis of dementia is life-shaking. It impacts not only the patient, but those around them and grows worse each day. Dementia comes in many forms. Next time, On Call with the Prairie Doc.
On Call with the Prairie Doc is very important to a lot of people in this area and in this region because it communicates a lot of very valuable information on healthcare. This project takes dollars. We have a great foundation called the Healing Words Foundation that oversees this whole operation and is responsible for some of the fundraising to promote these programs. So the website is prairiedoc.org, O-R-G, prairiedoc.org. Go there. Donate if you're so inclined, and we thank you very much.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the medical quality improvement organization for South Dakota. and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.